This is how the USMLE tests the Circle of Willis. Let's start off with the anatomy. So we have our ICA coming off anteriorly, and they're going to give off the ACA, the anterior cerebral artery, which is going to be joined by the anterior communicating artery. Now the internal carotids also give off the MCA, the middle cerebral artery, laterally. Now posteriorly, the vertebral arteries join to form the basilar artery, and then this divides into the PCA, which is the posterior cerebral artery. Now what connects the posterior circulation and the anterior circulation is this posterior communicating artery. Now let's localize the strokes. For ACA, this is going to affect the medial frontal or parietal lobe, so you're going to get greater leg weakness and sensory loss than your face and arm. And it may also give you things like urinary incontinence in the vignette. For an MCA stroke, this affects the lateral hemispheres, so you're going to get arm and face weakness greater than leg weakness. And another clue is if they give you aphasia, think the dominant hemisphere, typically the left. If they give you hemi-neglect, that's going to affect the non-dominant hemisphere, typically the right. Now, a PCA stroke affects the occipital lobe, so look out for contralateral homonymous hemianopia with macular sparing, because remember the macula is supplied by the MCA. Now the aneurysms. An ACOM aneurysm is a classic Barry aneurysm. If it ruptures, think subarachnoid hemorrhage and that classic thunderclap headache. Remember, Barry aneurysms are more common in polycystic kidney disease and connective tissue disorders. Also, because the anterior communicating is near the optic pathways, you can get a classic bitemporal hemianopia. And finally, a PCOM aneurysm you need to associate with a cranial nerve 3 palsy. Remember, cranial nerve 3, your oculomotor nerve, if this is damaged, you're going to get ptosis, a down-out blown pupil. Save this whiteboard for your exam.